Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The emergency kit and supplies are only useful in the fact that the knowledge to apply them is mandatory. If you do not know the emergency kit contents and supplies and how to apply them, you may put a patient in jeopardy at some future date. You must read the clinic procedure manual, Roman numeral number 11, emergency procedures, and be thoroughly familiar with all the information obtained in either clinic procedure manual or the supplement to the clinic procedure manual. The first part of the clinic procedure manual tells you about the actual procedures to follow in an emergency. This emergency may be a simple emergency, a burn, a laceration, an injury to a fellow student, to yourself, or to your patient. And it will also give you the procedures to follow in a life-threatening emergency. In any emergency, you, the student who are treating the patient, must stay with your patient. Never leave your patient. Send a nearby student to go get an instructor. The instructor on the floor or who's in charge of the clinic at that time. The instructor will then determine if an emergency kit, oxygen tank, or whatever supplies are necessary, and the student who is assisted by getting the instructor in the first place will go get these other supplies. If it is deemed necessary by the instructor in charge that this is a major emergency and he desires help of the code alert team, he will request the assisting student to go to the telephone and dial 3-HELP. This number is a direct line to the telephone system, and the student should at that time give the location, second floor, give the clinic, whatever color clinic, give the cubicle number to the person answering the phone. And then the student should go to the doorway and wait to direct the emergency team, which is a code alert team, to the cubicle where the emergency is in process. The student should then stand by to assist in whatever means is necessary at that time. Also, the emergency kit contents and locations are essential for every student to know. As you rotate through the different departments, you should be familiar with where the emergency kit is in that department and the oxygen tank is in that special department. On the first floor of the dental school, there are emergency kits in the perio and crown and bridge department. There are emergency kits in the pedodontics department, in the DAU clinic, in the oral diagnosis clinic, and in the periodontal surgery clinic. Also at the first floor dispensing, there is a kit. There's also a kit in the orthodontics department. On the second floor, there are kits located at the dispensing area, 2 kits and 2 oxygen tanks. There are kits located in oral surgery, partial denture, complete denture, endodontics, and graduate operative. On the third floor, there are 2 kits located at the dispensing, and there's also a kit in the perio research area in the research wing. In addition to these kits and oxygen tanks, there is also accessory supplies at each dispensing area. These supplies include a backboard, suction machine, blankets, and also extra equipment that is needed in a major emergency. There are 3 areas where there are locations of wheelchairs. This is in Dr. Comstock's office on the first floor opposite perio surgery. On the second floor, this is in the oral surgery area, and on the third floor, this is by the third floor dispensing. If you need a wheelchair, go to these areas to transport a patient. In addition to the locations of the various kits and supplies, you must know the drug descriptions. These are outlined in the clinic procedure manual. You must memorize the 12 drugs and be completely familiar with them so that you can assist in any manner deemed necessary by the faculty member who is in charge at that emergency. You must know the indications for the drug. You must know the actions of the drug. And only you will know the contraindications. You will know your patient's past medical history and must tell us if there are any contraindications to any of the emergency drugs that we will be using. you must know the normal dosage. The dosage listed in the manual are adult dosages, and you must take into account when dealing on a child or a smaller patient, the dosages must be reduced. You must know any precautions that are necessary with the drug usage. And lastly, you must know any special usage that is necessary when dealing with the drugs. In the dental school, there are going to be two types of kits that are going to be available to you. Because we have added some new kits, there are very large gray emergency kits that have all the supplies contained in them. The majority of kits are the red kits like this one. This kit is too small to contain some extra supplies that are always going to be right next to the kit. So whoever picks up the emergency kit must, if it's a red kit, must pick up the kit and the two supplies right next to it. To get into the emergency kit, all emergency kits are kept locked for security reasons. There is a small lock which you just bend to break it. Bend it back and forth. It breaks. You can open up the kit, and everything is right there in front of us. On the top of the emergency kit are going to be two sheets of paper. One is this packet of information I'm holding right here. This lists the supplies in the emergency kit. It lists the equipment on the top part, and on the bottom part it lists the drug in order of the sheets. When using any of the drugs, you should turn to the drug, and listed there will give us the name of the drug, both the brand and generic name, the indications, actions, contraindications, and depending on the drug, special precautions, dosage, or whatever. This is a very important sheet to turn to when administering drugs because it does help us with the dosage, which is very important because sometimes in the heat of the pressure of an emergency, the wrong dosage may be administered. In addition to this form, there is a very, very important form. This form is important from a medical legal standpoint and also for the patient's health. On this form, this is the emergency record. There will be carbon copies of it in there. This should be filled out as soon as practical during the emergency. In fact, the student who has assisted during the initial part of the emergency should start filling this out as soon as possible. The date should be filled out, the time of the event, the exact time of the event, the patient's name, and where applicable, the patient's registration number, the age of the patient, the sex of the patient, the exact location in the dental school, floor, clinic, and cubicle number, then a description of the event. Then the treatment before the event. The treatment may be use of local anesthetic, pre-medication, or whatever. Also should be listed under description of event the signs, the symptoms the patient may have manifest, any pertinent data from the patient's history that will either help the emergency team or help people at the emergency room of a hospital, such as patient has a history of epilepsy, patient has a history of cardiac arrest, patient has a history of drug usage, or whatever. The emergency treatment is also very, very important and must be filled out at that time. First, the time must be recorded, and then the vital signs. The vital signs are very, very important to record, such as blood pressure, pulse, and respiration, and associated signs and symptoms at that time. Then, any medication administered must be noted. The time of administration must be noted. The name of the drug must be noted. The dose used and route of administration used. Any comments such as adverse reactions to the drugs or positive reactions to the drugs must be listed under comments. The outcome of the event will either state the patient recovered in 20 minutes, and again listing the exact time, or anything else, or if the patient was turned over to an ambulance and removed to the hospital, this must be recorded. This sheet must be signed by the attending dentist or a member of the emergency team. A copy of this sheet must be sent to the hospital with the patient if the patient is transported to the hospital. This table contains all the drugs and supplies that are contained in the emergency kit, and they will handle any major emergency that is likely to occur in the dental office. The kit contains a sphygmomanometer and stethoscope, a IV solution of Dextrose solution, D5W, normal saline, a 1 cc prepackaged sterile syringe with needle attached, a 3 cc syringe with needle attached, a 10 cc syringe with needle attached, a set to administer IV solutions with a barrette and drip column, alcohol sponges to clean the site of the arm where the venipuncture is to be made, and also to clean the tops of the various vials that must be entered to obtain drugs, a butterfly needle apparatus for starting the IV, tape to hold the needle to the arm, a tourniquet to put around the arm to make the vessel stand out, an arm bar board to hold the arm stable and steady while administering IV drugs, a bite block on a tongue blade apparatus for epileptic attacks and convulsions to protect the masticator apparatus. Drugs in the kit are aromatic ammonia inhalants, an Allupent inhaler, preloaded and packaged Valium syringe, 10 milligrams, preloaded prepackaged sterile syringe with Benadryl, 50 milligrams per milliliter, high potency, a vial with Aminophylline, preloaded syringe of epinephrine with extra cartridges, 1 to 1,000 epinephrine, nitroglycerin, Hydrocortisone, a steroid, a preloaded syringe with sodium bicarbonate with needle already attached, 2 vials of Glucagon for injection, a preloaded syringe with 50% Dextrose solution, and lastly, a can of sweetened orange juice with 2 packets of sugar. The first drug mentioned in the clinic procedure manual is aromatic ammonia inhalants. This drug is used for the prevention of and for the treatment of syncope. The ammonia inhalant is a small glass vial that contains ammonia and alcohol mixture. It is wrapped in cotton and then has gauze protective over the top. This drug is administered by crushing the small glass vial away from the patient and then holding it 4 to 6 inches under the patient's nose. The patient's head must be held while administering the ammonia inhalant because it's an irritant and the patient may jerk suddenly and injure themselves. It is also extremely important to break this vial behind the patient's back away from their face in case any alcohol or ammonia mixture may splash out. So you'll grip the ammonia inhalant in the center, getting it at arm's length away, press down and hold your hand against the ammonia inhalant so that what will happen is it'll help drive off the vapors. Put your other hand on the patient's occipital part of the skull and then administer the inhalant 4 to 6 inches below the nose. That is all to administering the ammonia inhalant. The next drug we'll be demonstrating is an Allupent inhaler. It is metoprolol sulfate. It is primarily a beta-2 stimulating drug, therefore it is a potent bronchial dilator. It is used primarily in acute asthmatic attacks. The drug comes in this setup. It must be taken apart and put together properly. This is a storage method. The container is pulled from the administrator. The safety cap is removed. There is a small hole in there which lines up with the nipple on the top of the administrator. They're put together. It is turned upside down and shaken vigorously. The medication will crystallize out and must be shaken vigorously. To administer this to the patient, it must be in this form. The patient is then instructed to take and bite down around the rim of the administrator and then take and lock the lips around it. At that time, you will then tell the patient to completely exhale and inhale through the mouth and through the nose. At mid-inspiratory cycle, you give them 1 metered dose. Have them hold their breath for 30 seconds, exhale completely, and on inhalation, mid-cycle again, another dose, having them hold their breath for 30 seconds. Then take this away from them. Some asthmatics who have used this before will want to use it more than the normal 2 doses. Do not allow them to use it more than normal 2 doses every 5 to 6 minutes. The next drug is Valium. Valium comes in a prepackaged sterile container. Valium is used for the treatment of anxiety, for convulsions, and primarily for status epilepticus. It is a drug that can be used either IM or IV. IV usage is much more rapid, but administration IV entails much more care be used. The drug is in a pre-loaded box. You just tear open the end of the box. The syringe is preloaded, has a small protective plastic hub. This needle cover is pulled off, and the drug is all ready to use, and it is 1 milliliter for 5 milligrams, so it is already listed. The one thing that is essential to do whenever administering preloaded syringes is most of them have an air bubble in them, and perhaps you can see right where my thumb is here, right at the base of the needle, there is an air bubble in there. So before administering this drug, when you pull it out, after removing the protective hub, turn the syringe up, flick it twice to get all the air up to the top, press in your plunger to remove all the air bubbles. Now you know you'll have just fluid, and when you inject your patient, you will be putting in the proper dosage of Valium. The next drug we'll be discussing is Benadryl. Benadryl is a drug that is used in allergic reactions and as an adjunct in acute allergic reactions such as anaphylaxis. Benadryl is used either IV or IM. The range of dosage is 10 to 50 milligrams. If it's used IM, it's usually used 25 to 50 milligrams. IV or intravenously, it's used 10 to 25 milligrams. Benadryl comes in a sterile container. The box must be broken at the top. The preloaded syringe is pulled out. It has a plastic protective hub over the needle. This must be pulled off. And then this drug, the way it's loaded, is interesting in the fact that to ensure sterility, the needle hub here has a little insert that must be pushed down and activated before the drug can be administered. So you'll notice that what I must do in this case is push it down into tight contact with the top of the hub. This now allows the needle to penetrate into the solution. Also, the Benadryl has some air bubbles in it. The air bubble is gotten rid of, very similar to the last time. The bottle is tapped, and then the air is expelled and the drug is ready to administer either IV or IM as dictated by the emergency situation. The next drug we're going to be talking about is Aminophylline. The indications for Aminophylline are bronchial asthma, status asthmaticus, congestive heart failure, and emphysema. Its primary action is a smooth muscle relaxant and relaxes the bronchial airways and pulmonary blood vessels, so it's a bronchial dilator. This drug is used in an intravenous solution, so it must be taken from the vial here by syringe and injected into the IV bag of either dextrose or normal saline. To do this, you pick up the vial. It has a plastic top on it which ensures sterility, and this is where you'll be withdrawing the fluids from. You pop the top off, and that is sterile, so you wouldn't touch the little rubber stopper on it. You'll pick up your syringe, and you'd probably use the 10 cc syringe. Tear back the two butterfly wings. Tear back your needle that's held on the syringe paper. Unscrewing the protective cap. Screw the syringe to the needle and remove the needle protector cap. Now, test your plunger. Then take and have about 1 millimeter to 1.5 millimeters of air. Insert it into the top, turn it upside down, inject some air into the bottle, and then withdraw the amount that is necessary. The Aminophylline comes at 25 milligrams per milliliter. So depending on your patient's size, you can draw however much you need out of the vial, and then with your syringe, inject this directly into the intravenous solution. And I'll be showing you this when I talk about the intravenous solution. The next drug is epinephrine 1 to 1,000 in 1 milliliter ampules. The indications are acute asthmatic attacks and anaphylactic reactions. It acts on both the alpha and beta receptors, therefore it's a bronchial dilator, combats bronchial spasm, laryngeal edema, acute hypotension, and release of histamine. It is also a stimulant to the myocardium, which makes for one of its precautions, which is must be used very carefully in patients over the age of 40 because of possible cardiac toxicity, arrhythmogenicity, causing arrhythmias. The usual adult dosage is 0.3 to 0.5 cc, either IM or subcutaneously. The dosage may be repeated every 5 to 15 minutes. This comes as a pack of extracarpials for repeat doses and a loading syringe. The syringe is taped to the extracarpials, and the syringe loads like the old single shotgun type where you pull back on the plunger, bend it open, and then you can insert your new carpial. The thing that is interesting in this new technique, so that you can aspirate and make sure you are not in a blood vessel, because you do not want to give this drug intravenously, is at the end there is a little metal screw on the end of the rubber stopper. This metal screw must be screwed on to the plunger. So when replacing this carpial or using this, the carpial is inserted point first, trying to make sure you leave the millimeter markings up where you can see it. The plunger is pulled back, inserted into place, and then screwed down tight. Now it's tight, you can aspirate, and you can also get rid of the air bubble just like on any other syringe. You'd remove the protective cover here, hold it up, flip the air bubble off, and remove the air. And if you need to do more carpials, they're right in this container and insert very easily. next drug is nitroglycerin. The brand name is Nitrostat, a very stable form of nitroglycerin which has a much longer shelf life. The indications are for treatment of angina pectoris, which is a lack of oxygen to the myocardium. The actions are it redistributes coronary blood flow, dilates peripheral vessels, therefore decreasing the peripheral resistance. The dosage is 1 tablet sublingually. You'll take and place 1 tablet in the floor of the mouth, underneath the tongue, and most people who are in pain have a dry mouth, so add just a little squirt of water to help the tablet dissolve, and then you wait 5 minutes, and if there's still pain, the tablet may be repeated in 5 minutes, another tablet placed, for a total of 3 tablets. While administering the nitroglycerin, the patient should also be put on oxygen at a flow rate of 4 to 6 liters per minute of 100% oxygen. The nitroglycerin tablets are very, very small, and let me just show you how large they are. The nitroglycerin tablets are approximately the same size as like some of the artificial sweeteners. So it will be 1 of these tablets sublingually with a small squirt of water for treatment of angina pectoris. The next drug is Hydrocortisone, which is a form of hydrocortisone. Its indications are in the use of existing or potential states of acute adrenal cortical insufficiency, which is characterized by circulatory collapse, fall in blood pressure, rising pulse rate, and coma. Also, it may be used when treating patients with allergic drug reactions and status asthmaticus. It's an anti-inflammatory adrenocortical steroid. It is used either IV or IM, depending on the situations. The normal adult dosage is 50 to 100 milligrams IV, and then 10 milligrams with an IV drip per hour, or an alternate method is 100 milligrams deep IM. Because the drug is unstable, it has a special type of container that it is kept in, this vial. This is a mixing vial. The mixing vial has a plastic protective cap on the top, a powder is in the bottom, and a liquid is in the top. To get these two to mix together, you pull off the plastic protective top, and you'll notice there's a plunger. You take and hold this between your thumb and the bottom part of the jar, and by pressing in, it forces the cork that was in the center out of the way, and if you notice, the fluid has now dropped down into the part where the powder was. This is then vigorously shaken up, and the little plunger is actually used to help mix it. Vigorously mixed, and then the solution should be somewhat clear. You take an alcohol sponge, if you have time, an alcohol sponge or swab, clean off the top, take your syringe, which you've already prepared, as I showed you in one of the previous sequences, draw back about a cc to a cc and a half of air, insert through that clean sterile top, turn upside down, insert your air in there so that when you withdraw the fluid, you won't have a vacuum. Now I've got my fingers over the top, but I'll show you. So now you have the bevel of the needle up and just in the solution. Then you gradually draw back how much you need. And then this may either be given IV or may be given IM or injected into an intravenous solution. The next drug is sodium bicarbonate. The indications are corrects metabolic acidosis in the treatment of cardiac arrest. It does that by increasing the plasma bicarbonate, buffers excessive hydrogen ion, raises the blood pH, and reverses all the clinical manifestations of acidosis, which interferes with proper cardiopulmonary resuscitation. Its use is intravenous. This comes in a preloaded, called Bristol jet syringe. And how this is used is you tear open the box and you have your syringe and your solution. To incorporate these two together, you remove the protective cuffs and then there's a screw mechanism, insert the needle in and screw it down tight. Once it is screwed completely tight like that, then the needle has penetrated into the vial. You remove the protective needle, and this may be inserted directly intravenously. It may be inserted into an IV line, and all you do is hold it in your palm and just press in. And as you notice, I'm just pressing and forcing it right in. The next drug is Glucagon. Glucagon, the indications are severe hypoglycemic reactions in diabetic patients. There's a much better response in adult-type stable diabetic than in a juvenile type of diabetes. Its actions, it's a pancreatic hormone. Therefore, it increases blood glucose concentration and is used to treat the hypoglycemic states. It acts on liver glycogen, converting it to glucose. It may be used subcutaneously, intramuscularly, or intravenously. The dosage in the adult is a half to 1 unit of glucagon, either sub-Q, IM, or IV. If there is no response, such as an awakening of the patient in 5 to 20 minutes, an additional 1 to 2 doses may be administered. Glucagon comes in 2 separate vials which must be mixed together. The 2 vials are separated. There's one vial of sterile fluid and then a vial of powder. There is a flip-off cap, which is similar to some of the other drugs we have seen. The caps are broken and flipped off. And then we are all ready to inject. We have already shown how to prepare the syringe. Our syringe is prepared. We have tested the plunger. We draw in about 1 millimeter to 1.5 millimeters of air, and we go directly into the fluid bottle, inject our air, and that helps us easily withdraw the fluid. We have the bevel up and be below the surface. We withdraw the fluid carefully and pour out. In this case, we do want an air bubble because we're going to be injecting into another vial. So we do want a small air bubble. Now we inject into the powder, inject our fluid in, pull out the needle, shake vigorously until the solution becomes clear. Draw in about 0.5 cc of air, go back into the bottle, inject your air, invert so your fluid level is covering the bevel of the needle, and withdraw the desired amount. And then this may be administered to the patient either IV, IM, or sub-Q. The next drug is 50% dextrose solution. The 50% dextrose solution is used to treat insulin hypoglycemia, to store a blood glucose, especially in a diabetic patient who is a brittle patient and very difficult to control. Actions: it restores blood glucose levels in hypoglycemia. It must be given IV, and it should be injected slowly through a small bore needle into a very large vein. The usual adult dosage is 10 to 25 grams, which is 20 to 50 milliliters, IV slowly. Before, if at all possible, administering the dextrose, you should take a specimen of blood which can be sent to the laboratory or to the emergency room to be analyzed. This tube comes in a preloaded syringe and is very similar to the Bristol jet which was used for the sodium bicarbonate. Again, the box is opened, the two containers are withdrawn, the sterility seals are removed, the solution is screwed on tight till the needle penetrates the blue stopper. Here you'll see the milliliter markings. Again, remove the protective hub, and it is just pressed in as a normal injection technique. The can of sweetened orange juice and the packets of sugar are in the emergency kit to combat hypoglycemia. This hypoglycemia may be a diabetic who is telling you they are going into a hypoglycemic reaction and need some sugar quickly. Orange juice is an ideal vehicle because it's very readily absorbed, and with the extra sugar, which is sucrose, very quickly helps them out of a minor crisis. This should also be used with anybody who is undergone syncope. A lot of times hypoglycemia predisposes to syncope even after a person has had a very large meal. Their blood glucose is not high enough. To use, just pour the orange juice into a glass, one of our paper cups, mix in 1 or 2 packets of sugar, have the patient drink it down as long as they are conscious, and you should have no problems with administration of orange juice. It's perfectly safe to use in any situation as long as the patient is conscious and you suspect them of being diabetic or having a hypoglycemic reaction. Next, I'll be demonstrating the placement and apparatus of an IV. First off, someone will be using this, the male adapter, for the IV placement. This is a butterfly tip. Comes in a sterile package. You will hold it by the 2 wings, remove the plastic protective hub, insert this into a vein. This is taped down. Blood will fill the tubing. Once the patient's arm is all set, then you must connect up the rest of the IV. To start with, you'll be using the solution, which comes in plastic containers now, so there's less of a chance of breakage. There's a notch at the top of the bag, and this is just torn away. That ensures sterility. The bag is removed, and in this case, we are using D5W or Dextrose solution. To prepare this to be administered, you can hook this up on your IV bracket table or IV stand. On the bracket table, we can hook this up over one of the many adapters that will hold our handpieces on. We will be using this part down here to insert the intravenous set. Pull this off. And that's where we'll be inserting in. The venous set comes in a separate container. You open up the box, pull out the apparatus, and it has several parts. This part here will go into the IV bag. We have a bullet which we use to fill up, and we see how much solution is going on. There's a drip chamber here, and 15 drips equal 1 milliliter. The tubing, there's another stopcock that is used, thumb screw type, to stop the solution, regulate the flow of the solution. There is a Y area where the brown top is. That's where you can inject directly into the intravenous solution. And then lastly, at the very end, is a protective cover that is removed, and this is inserted into the back of the needle in the arm. So I'll be putting this together at this time. When putting it together, you close off the main sliding stopcock. You close the thumb screw completely closed. Remove the protective cover, and there you'll see you have a needle point. To be inserted, there must be fluid down at the base of the IV bag. So you have to hold the bag up somewhat, and it goes right into this area, and then is just pushed into place. Now it's pushed into place, you leave the bottom thumb screw closed and open the top. Now fluid is going into the bag, and we should put in there about 25 to 30 up to 50. Now that's closed off. Again, we want to stop the flow. So the flow is stopped. Now what we'll do is, leaving the bottom one still closed, just squeeze to get some fluid into the drip chamber. There's a small line on the drip chamber, which I don't know if you're able to see or not, but we would get it up to at least there. Now, without removing the very end protective cover, we would open up the thumb screw and get our fluid going through our line. We're trying to chase all the air out of the line. And once the fluid level has gotten all the way down to the end, then we close everything off again. So now there's fluid completely through all the tubing. There's no air anywhere in the tubing. This that I'm holding in my left arm, the IV bag and everything, would be on an IV pole right now, so I'd have two hands free. In this case, I'm just going to set it down. Now, the needle that is in the patient's arm, you would remove the back part of the protective cover on it, remove the part from the IV tubing, push them together like a telephone jack, and then you can adjust your flow rate at any level you want by adjusting this, the main shutoff, and the thumb screw. There are three areas where you may inject into an intravenous setup. You may inject a drug into the bag, and in this case, you would use this blue portal right here. Or if you want to inject the drug further down the IV line, where you can mix in a diluted solution, you can inject right into this area here. Or if you want to get the drug more rapidly into the person, you don't need to dilute the drug, or you want more rapid action, you could follow the tubing right down and inject right at this Y area right before the needle. So there's a very short distance and it gets into the patient much faster. Each one of these cases, all you would do is take and wipe off the injection site with alcohol, insert your needle in, and then put in the desired milliliters of whatever drug you're going to be using. At the dispensing areas, we have these backboards. These backboards have been designed to fit our dental chairs. If you attempt to do CPR, cardiopulmonary resuscitation, in the dental chair, the chair is very flexible and soft, and you do not achieve sufficient force to expel blood out of their heart. These backboards are used in the chair. The patient is rolled to one side, the board is slipped under the patient's back. Between the two armrests, the patient is then placed back on the board, and this gives us a firm area to press on to do our chest compressions. Also at the dispensing area is the ambu bags. Ambu bags, some are connected up to the oxygen machines, most will be separate. The ambu bag is a way of giving oxygen to a person that is almost as efficient as mouth-to-mouth resuscitation, but it allows the person to have their mouth free to talk and you put this on the patient and then press and inflate the patient. This is positive pressure breathing. So this part will go over the patient's face. You notice it is clear plastic, so if the patient should vomit or so, we can see it and be able to clean the patient out readily. It has a one-way valve that has air coming in and air going out. The bag part will take in room air. There is also a nipple at the end of the bag that can be hooked up to the oxygen tank, so we can have room air and oxygen mixed, or with a cap here, 100% oxygen going into the patient. It is held on the patient's head is extended, and it's just pressed like that to deliver the oxygen at the needed ratio or rate during CPR. The use of oxygen is important in a vast majority of the medical emergencies that we'll be treating in the dental school. The oxygen tanks are located at the dispensing areas and in the special clinics. The oxygen tank comes on a portable apparatus to move it around and has a area to put over the patient's face, has a bag to watch for filling and release of the oxygen. To get oxygen from the tank into the regulator mechanism, you must first open up the top part. And then there are two valves, and the one valve will show how many cc's of oxygen are remaining in the tank. The other valve shows how many liters a minute of oxygen we are using. You want to regulate it in the average situation where a person is conscious and breathing to about 4 to 6 liters a minute, and then go up or down as to how much the patient is breathing. So all that's necessary is just to open the valve until you get the proper amount of oxygen going to the patient. This ends the tape on emergency procedures. You must review the drugs, must review the information on emergency procedures in the clinic procedure manual, and be prepared at any time to administer the drugs and the supplies wisely to help a patient.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.